Hi, everybody. Thank you so much for coming today. Welcome to our workshop on Navajo maternal and child health, which was planned in conjunction with Diné College and funded by the Arizona Biomedical Research Center, affectionately known as ABRC. ABRC was created by Arizona citizens who set aside tobacco and lottery revenue to identify and support innovative biomedical research to improve the health of all Arizonans. ABRC has funded Northern Arizona University and the Center for Health Equity Research with grants to offer conferences over the past several years. And we're very thankful for their support and their initiatives for Northern Arizona. We should also recognize our partners who collaborated on this needs assessment: the Arizona and New Mexico Departments of Health, the Navajo Epidemiology Center, the Navajo Department of Health, Navajo Nation, Diné College, and NAU's Center for Health Equity Research. I should add that there were many others involved in the process, too numerous to name individually. It takes a significant team effort to put together a report of this magnitude with the potential for such an amazing impact. To date, we have over 120 people registered, and we are so pleased with that turnout. Please note that the full report is available online, and I'll post that link in our chat as soon as I'm finished talking here. So in the next couple hours, we're going to take a deep dive into the approaches used to collect meaningful data from Navajo mothers and healthcare professionals to compile the first Navajo Nation specific maternal and child health report. Sit back and prepare to be impressed by the level, scope, and impact of the work on this needs assessment.
Righty. Good morning, everyone, and thank you for that introduction, Linda. Yat bene she Amber Rose Waters inishia Hashkan Hadzohe Nishlan Tukchitni Bushes Chain Kabaha Dashache Nakaidene Dashanale Dene College de Nashnish Natani Nez de Nasha do Tota Kehashtke. Hi, everyone. My name is Amber Rose Waters, and I am the project coordinator for the Navajo Maternal and Child Health Project at Diné College. And we were able to complete the first Navajo MCH needs assessment report between our partnership, the Navajo NARCH, or Native American Research Centers for Health, which is between Diné College and Northern Arizona University. And I just want to say thank you all for joining us today. I have my colleagues on the line also, and I'm really excited to be presenting this. And I just wanted to give you a little bit more about my background. I do live on, I'm from the Navajo Nation. I was born and raised in CHER, New Mexico, and that is in the Northern Agency. I have two daughters. One is Maria and one is Leia, and they are, my guiding forces, through my education and my life and my work. And so I'm really excited to be and honored to be a part of, this process, putting together, this first, needs assessment report, and also to just be continuing this work nation. So I am going to share my screen now, and let's see. Give me a second here. All righty. And I would like to say, if you have any questions, we do have a panel session happening at the end of this workshop. So you can go ahead and put them, any questions that come to mind, in the chat box, and then we can get to them at the end of the session. But that is myself and my two kids on the cover of the report. And let me continue. So I would like to provide a brief overview of the Navajo Nation. There are 332,000 enrolled members, with 47% living on the Navajo Nation. To the left is a map, and it's divided, as you can see, the Navajo Nation is divided into the 5 agencies with 110 local governing chapters. There are 13 grocery stores, 17 hospitals, and other smaller clinics. And we do have the Navajo Epidemiology Center located in Window Rock, Arizona. And also for this needs assessment, we wanted to highlight environmental health issues that continue to impact the health of the Navajo people today. And so now I'm going to talk about our framework that we adapted from a teaching called Sa'ah Nagay Bik'eh Hojon. This is a teaching and a principle used on the Navajo or among the Navajo people. And so the Navajo culture is a matrilineal society, and Navajo women are sacred because of their role in bringing about life. Children are also sacred because they carry on the Navajo teachings and language. So we decided to use this framework to describe the needs assessment process. So Sa'ah Nagay Bik'eh Hojon is also, it means to live a long life in harmony and balance. And so we have teachings and prayers and songs that help us to maintain that balance. And so if, one were to get off track, they could, seek help and also use those tools to get back on track with SNBH. So this framework is usually cyclical, but we decided to incorporate it into the traditional Navajo Hogan because the Hogan for Navajo is a safe space where growth, development, teachings, and ceremonies take place. So at the bottom, we start at the foundation of the Hogan, number 1, which is Nitsaha Kes, which is thinking. And at this stage, we built on our knowledge and understanding of mothers and children. And then number 2 to the left is Nahat'ah, or planning. And this makes up the structure of the Hogan. And at this stage, we partnered and met with our Navajo Epidemiology Center, Northern Arizona University, our public health students, and established our advisory council. And third, to the right is INA, which is implementation. This also makes up the structure of the Hogan. In this phase, we conducted our data collection, including the primary and secondary data and analysis. And here we're able to continue to engage with our partners and advisory council for guidance and support. And also we held our priority setting with our stakeholders. And the last phase, which is the roof, number 4, it's Sihasin, or reflecting. And this is represented by the roof of the Hogan. And here we identified the unmet needs within presentations in our final report and other dissemination activities. Like we also created infographics, and we're continuing to provide presentations across Navajo, or on and off Navajo actually. And here we have our approach to our findings. And this was based on the 4 directions, or the 4 cardinal directions that are associated with the several teachings, sacred deities, and times within the life cycle for Dene. And self-identity, familial roles, and culturally significant milestones are emphasized regularly at ceremonies that celebrate a baby's first laugh, a child's coming of age ceremony, a new partnership, and reaching old age. So with this in mind, we view all aspects of health as being related to physical, emotional, spiritual health, and our relationship to the land. We begin in the east when life first begins, with the perinatal from birth to 5 years, to the south as a child 6 to 11 years, to the west as an adolescent for between 12 to 17 years, and the north, which represents adulthood and maternal health. And so this is how we were able to approach the needs assessment. And so we broke down, our data analysis between these different ages and areas. And next, I'm going to talk about our needs assessment partners. So we collaborated with Dene College. Again, as I stated before, this was a collaboration between Dene College and Northern Arizona University as part of our Navajo-NARCH partnership, as well as the Navajo Epidemiology Center, with funding and support from the Arizona Department of Health Services. And we had a primary team, which consists of our NARCH partnership, as well as our public health senior level students. And just to let you know, we do have a student that was part of that, the needs assessment process, who's going to be a panelist at the end. So if you have any questions about their experience, we do have one student on. And also we were able to establish an advisory council based on a pre-established advisory group that was the PRAMS, which is the Pregnancy Risk Assessment Monitoring System for Navajo. So we had partners that were in New Mexico and Arizona and Utah that were PRAMS affiliated. And so we were able to utilize that advisory council for this needs assessment process because they did have already gathered providers, state and tribal program specialists, Navajo area stakeholders, and also the New Mexico, Arizona, and Utah state health departments. And this was very vital to this needs assessment process because they are, the advisory council members are those that already work with mothers and children on Navajo, so they have the input and the feedback that is needed to conduct such a needs assessment. And so now I'm going to talk about the public health students a little bit. We did have 9 senior level undergraduate public health students that were part of a one of their senior capstone courses. And so we had them, we assigned them a section of data to analyze, and the assigned sections are to the right there. It includes the perinatal and infant, child, adolescent, women's and maternal, children with special healthcare needs, and environmental health. And so we were able to, myself and 2 other instructors were able to guide them in data analysis, as well as creating tables and graphs and establishing preliminary priority areas based on the disparities that we saw within the data. And then for they based their final capstone projects on the data that they analyzed. So, and they also assisted in writing their data or a report on their section. And so this is just showing you the process that we had taken. So we were first approached by Arizona Department of Health Services and the Navajo Epidemiology Center. During this time, the pandemic started. So they had reached, the Navajo Epicenter had reached out to Diné College to complete the needs assessment, which we partnered in the past on other projects. So we were excited and willing to take on this opportunity. And so from there, we decided to assemble and assign roles. So with Diné College took on the secondary data collection along with our public health students. And then Northern Arizona University took on the primary data collection. And from there, once the data was collected and analyzed, and then throughout this whole process, again, we did meet monthly with our advisory council if there were any questions, and they were really vital in helping us to come up with some questions, as well as distributing our questionnaires for the qualitative data collection. And once we established preliminary priority areas and we gathered the findings from the qualitative analysis, we held priority setting sessions, and they were all virtual due to the pandemic, and they happened in May of last year, I believe, May or June. And from there, we were able to set the priorities based on the health data that we collected and create and write a report, and also continue to disseminate the results. And now we're going to go into the workshop part of this webinar. I'm going to demonstrate how we took on the quantitative data collection, and I will need some assistance from my colleague, Dr. Christopher Dickerson, who was also part of the quantitative data collection with Diné College. So these are our secondary data sources. So we were able to gather information from Navajo reports so these are reports that were already completed by the Navajo Epidemiology Center. So we had a Navajo health survey, which took place in, I believe, 2016, and hospitalizations report, mortality reports, the youth risk behavior survey for Navajo specifically, and also hospital data, some hospital data, breastfeeding data, GIPRA data, and birth defects data. So some of these were available on the Navajo Epidemiology Center website, and some were actually provided by our advisory council, including like Arizona Department of Health, New Mexico Department of Health. And so next I'll go on to online data sets. We utilize the American Community Survey to look at demographic data, as well as to include in the beginning of our report. And we also use the CDC Wonder database, which utilizes birth and death data by county. So it's summarized data, and some data we weren't able to access just due to population numbers. We had to be able to, or the counties that we had access had to be above 100,000 population wise. So we could only use data from 3 counties, and that included Navajo and Coco Nino in Arizona and San Juan County in New Mexico. And those 3 counties are located on Navajo. And also we received a link to an immunizations reporting website or database from one of our advisory council members. And then for data requests, we were able to provide, we're able to request data from the PRAMS, or the Pregnancy Risk Assessment Monitoring System, in New Mexico and Arizona. And again, the PRAMS conducts a survey among mothers that asks about their behaviors and experiences before, during, and after pregnancy. And we also were able to request some data from the Navajo Health Survey that was completed by the Navajo Epicenter. And we wanted only women's responses, so they were able to complete that data request. But keep in mind, this was during the pandemic, so we weren't able to get as much data as we'd like to, or as we'd hope, as well as more recent data. And then for our for this needs assessment specifically, we felt that it was important to report on environmental health issues, because this continues to affect Navajo people and their health today. So we were able to conduct a review of previous research conducted on Navajo, and we looked at the Navajo birth cohort study, abandoned uranium mining, water and air quality, and we were able to receive a fatal car crashes report, as well as data and also information on food access. So talk a little about the Navajo Epicenter. This is funded through Indian Health Services, and there are 12 tribal epicenters that exist across the United States. And to the right, there is a map of this. And then, so this really helped us with our secondary data review. This enabled us to access existing health reports to see how health has changed over the years, if we were able to access more recent data. And then we're able to make data requests. Again, if we were, it was during the pandemic, so it was kind of limited on the kind of data that they were able to provide. But, we would be able to do this in the future with them, make data requests, and they had access to the Indian Health Services data mart. So if there are specific health indicators that we wanted to look at for mothers and children, they would be able to access that and provide that information. And also working with the Navajo Epi team, they were able to provide vital feedback to, what kind of data is out there for us to review how should we be analyzing this data. And so they were very, they were able to guide us in that way. And so I'm going to actually stop share and I'm going to take you to the Navajo Epicenter website. And let's see. Okay. Alrighty, let me go back and start sharing my screen. So this is the Navajo Epidemiology Center website. As you can see, the report is located here, as well as a PowerPoint that we are able to create to help general community members or any programs or officials to understand the needs assessment. And here we're able to access some of their reports. And we do have the needs assessment here, our slides, but one report specifically is the fatal car crashes report. And as well as the Navajo mortality report. And as you can see, they have, reports from 2010 to 2013 and one from 2006 to 2009. So we really had to, we're kind of working with a little older data, which was fine. It helped us to understand Navajo health, and going forward, going to conduct the next needs assessment. We may be able to collect more recent data and compare, look at the trends, including, let's see, so they also have the Navajo Youth Risk Behavior Survey report for middle school and high school in 2011. And as I mentioned earlier, the Navajo Health Survey, which was completed or started in 2013, I think it was completed in 2016. So this is the report where we requested only women's responses. And previously, the Navajo Epicenter was working with New Mexico and Arizona Department of, not Department of Health, with the PRAMs. So they were able to come up with their own reports based on, types of questions that the PRAMs asks about. So we are able to look at actually, since this covers things like breastfeeding, mental health, violence, and just overall women's health, we're able to look at the previous data. And then once we made our data request to New Mexico PRAMs for more recent data, we're able to analyze or see if, health was improving, in what ways, and also we're able to establish, our priority areas based on that. So it was really helpful to have these reports already available in order for us to compare the data and see how we're improving or see where we need to improve. So that's what I wanted to share with you. I will go back to the PowerPoint now. And so next I'm going to talk about the online data set. So like I mentioned, we accessed the American Community Survey. It's called the My Tribal Area, and this helped us to gather demographic data on the Navajo Nation. And I believe they use 5-year estimates from the American Community Survey. So again, I'm going to take you to that. And at the beginning of the report, if you already reviewed it, there is the information that we used from that. Let's see, did it pop up? Nope, it did not. Hold on. Okay. So you should be seeing My Tribal Area, census.gov. And so here it provides information on people. Oh, right, I have to, well, first you have to choose the area that you're wanting to look into. Why should actually. So we have Navajo Nation here. So it gives you population data, employment data, which is very helpful. and understanding the social determinants of, the health on Navajo. And then also housing, the economy, and education. So now I will go back to the presentation. I hope I'm not, I hope you're able to follow along. And next is the CDC Wonder data, which again provided county level data on birth and deaths. And again, this was it was a little tricky for me to understand, but Dr. Christopher Dickerson was very helpful in this. I wouldn't have known, as a project coordinator, that this type of site existed. So let's see, now I will have to go back to this here. So it's a site where you're able to request data. So this is what it looks like. And here we go to, as you can see, they have, other data that they are able to collect in different areas, but we would go to births, natality data for 2016 to 2019. And then we're able to, we agreed to the terms. And here, so this is how we were able to get some of our birth data and our maternal health data. So what you would do is you would select, let's see, you would select, I think that's right, census region of residence. If you wanted birth rates or any of these here, you would click. But here's where you just have to get used to doing different requests and how to go about it. So you would click Arizona, or we would have to click Arizona. We would click open, and so it was kind of tedious. It took some time, but we got used to it. So we would select Coco Nino and Navajo. Coco Nino and Navajo County. And you would just, click open again, just so it sticks. And then since we wanted to also look at, since the Navajo Nation is located on New Mexico and Arizona, oh, it didn't stay. Oh, I know what I have to do. Okay. So here, sorry, give me a, all right, I think I know what I did wrong, but.
Open New Mexico.
That's what I thought I did.
Well, you opened Arizona. You should be able to hit open now.
Okay.
And they'll both open.
All right.
And now you can select, yeah.
Okay. Thank you. Navajo and Coco Nino, right. So again, these are the only counties that had populations above 100,000. So that's why we only selected those 3 counties. And then you can go down here and select American Indian or Alaskan Native. And then you can go on to select any of these other, health or indicators that you wanted to look at. So I believe we went ahead and just clicked all ages. We weren't really too concerned about education, marital status, or even paternal characteristics. But here it goes into pregnancy history and prenatal care. So one of the health indicators that we looked at were pregnancy intervals and WIC, if they were enrolled in WIC. Let's see, and then also trimester prenatal care began. So let me just demonstrate one here for you. So let's do first to third. Well, let's see. Or let me actually do something a little bit easier. So here's maternal risk factors. We definitely looked at cigarette usage, tobacco use, pre-pregnancy BMI, and then other risk factors, diabetes, gestational diabetes. So I will just go ahead and look at gestational diabetes and
Now,
yes.
one of the values of this is that you can actually group by some of these different, well, basically by all of these different potential outcomes up at the top. So scroll up
Okay.
and we'll,
All the way up.
yes.
Okay.
And so under census region of residence, select, no, the one below it, the
Okay.
drop down below it.
Got it.
Scroll further down. WIC. Just click on WIC.
Got it.
So now we'll be able to not only look at gestational diabetes, but it will be divided out by whether the woman was a WIC participant or not.
Mhm.
And I see several people have asked, why did we only use 100,000? CDC, the Wonder website, through the publicly available information, only releases data on a geography if the population is 100,000 or larger. And the reason for that is to ensure privacy, basically prevent researchers who might illegally and maliciously try to access the data for identifying individuals. There may be ways to work around this in the future, but given the time constraints that we had, we could only use the data that was publicly accessible through the website. So that's why we only chose counties over 100,000, because that's all we could.
Okay. All righty. Thank you for answering that question and making that clear, Christopher.
Mm-hmm.
So we would just, so other things that they have here, you know, they have more pregnancy risk factors, maternal infections, labor characteristics, delivery characteristics, and I feel like I'm going too fast, so sorry if I am. As well as maternal morbidity, infant characteristics. So now it goes into the statistics and abnormal conditions of the newborn. And so here, and Christopher, I may need your help again. We would do show zero values, right?
Yes.
And then that's, I don't want to export them right now. So I
No, we don't want to export them, because that simply exports them to a text file that you would open in Excel. We simply want to see the numbers.
Yes. So these are, this is what it creates, like a table. So you're able to download it, but you're also able to just view it here. And so as you can see, based on the CDC Wonder, those women that had gestational diabetes and if they were enrolled in WIC or not. So you can see 181 in those 3 counties only, that is. 181 were enrolled and 176 weren't. So that's just one way. And then they also provide, the information, the caveats, as well as any citations if you're going to use this information. So that's one data source that was very helpful in understanding the health of, infants and as well as mothers on Navajo. Let's see here. Okay, now I'm going to stop share and go back to the PowerPoint. And the other online data set that we had was Indian Health Services national immunization reporting. So I'm going to take us there now. And here we were able to access immunization data through this website here. And so it reports it by quarter. So, you click the area and it has Navajo available. And it has these different report types. So I believe the ones that we looked into were the adolescent report, as well as we looked into the 2-year-old and 3 to 27-month-old, and then the adult report. But let me take you to the adolescent. And depending on, let's see. Okay, so that's now. Let's go back to maybe last year. I should have gone back. So you just click generate report, and then here it gives you it gives you the data on these different vaccinations, breaks it down by ages, if available. So it gives you the total, it looks like, and the percent. So let's see, 2 years. So you see, one thing we looked at also was HPV for adolescents. So that was females. And then this is males. And then also tells you which facility reported these numbers, which is helpful in understanding where this data is coming from. And then it also gives further reports, which is, let's see. Yeah, so if you wanted to access immunizations data and something like this exists, you're able to request and get this data and use it for your reporting. Let's see. Okay, and now I'm going to stop share. So again, just keep in mind, we were trying to collect data, as much data as we could, or the most recent data, Navajo specific data, as we could during during the start of the pandemic. So it was a little difficult and a little challenging. And so these online data sets helped so much with accessing the kind of data that it covers. And now I'll talk about our data requests. So again, we did request data from the PRAMs, and that was for New Mexico and Arizona. And we asked for a breakdown of Navajo responses only. And so this helped us in understanding, mothers' behaviors and experiences before, during, and after pregnancy. And then we had also requested the women's responses from the Navajo Health Survey through the Navajo Epidemiology Center. And we also did individual Navajo area maternal and child health program data requests. So we typed out a letter and in which we indicated the kind of data that we would like to have based on, the kind of data that's requested within a needs assessment. So for instance, for BIE in public schools and charter schools, we just wanted to know, how many children were enrolled and any programs that they had, as well as, when for social services, we requested, if they had any referral or number of referrals, number of children in social services, number of children, transitioning out of social services. So just trying to understand these programs, or these programs that serve Navajo families, and also the early childhood intervention data. We requested, number of children enrolled, number of referrals, if any, types of services. So we really wanted to understand, what's there, what's needed, as well as try to, get some data in order to report it within the needs assessment. And if they weren't able to provide any data, we would invite them to be a part of our advisory council, because these are, education and social services and early intervention programs are, their input and their feedback is vital to understanding the health needs of, Navajo families. So if they weren't able to provide program, which was also understandable due to, a lot of them were responding to COVID and working remotely. Other challenges though were they weren't able to readily provide us data. They either did not have a database of that sort or somebody to provide the data. So that was an area that we saw that, needed to be addressed. So we, as part of our work today going forward, we would like to help to provide these programs with a database of some kind, even something simple as Excel, working, using Excel to store data, that might be helpful for program capacity and improvement, as well as in the future, we could go back and ask them, if we could, or if they're able to provide this data for the next needs assessment. So we're just getting that, started. So I'm really excited to be able to work together and collaborate further to meet their program needs and build their capacity, as well as to help, understand what's needed within education, social services, but also other MCH programs and services. And next, so once we were able to gather all of this data, all the secondary data, again, we tried to retrieve data from the most recent reports on Navajo, and we did our best to collect some education, disability, and demographic data, as well as review those environmental health reports. We used national, US, and American Indian Alaska Native data to compare rates. So we use Healthy People 2020 and for overall US as well as American Indian Alaska Native to compare the Navajo rates to the overall rates. And there we were able to identify disparities. So this is the work that myself, Dr. Dickerson, as well as our public health students conducted or completed. And if there were, disparities, those were actually noted as our preliminary priority areas. So for each of those population domains, we had some preliminary priority areas already set ahead of our priority setting sessions. So let's see. And now I would like to go over some of the data that we collected. And actually this infant mortality is our first priority set for perinatal and infant health. And as you can see, sudden infant death syndrome was the highest cause of death at 10.4%, with the total being between 2006 and 2009, 48. So this, again, we use the CDC Wonder to determine infant mortality, and that includes preterm birth, which is 37 weeks or less than 37 weeks. And then preterm birth comparison, again, using the CDC Wonder. So this is our second priority area that we set for perinatal and infant health. And so for preterm birth, the Healthy People 2020 goal is 9.4%. But as you can see, the Navajo estimate, which are the two bars to the left, they are above that goal. So we want to be below that. And this was between the years 2016 and 2017. When we compared it to the American Indian Alaska Native rate, which was higher than that goal, and then the overall US was sitting at 10% for both of those years. So overall, there is some work to be done to decrease preterm birth on Navajo and across American Indian Alaska Native communities. And next we go into breastfeeding. And this was using the Pregnancy Risk Assessment Monitoring System, or PRAMS, the Navajo only responses for New Mexico and Arizona. So the Healthy People 2020 target for ever breastfed is 81.9%. And according to the New Mexico PRAMS from 2016 to 2018, 70.6% of mothers reported breastfeeding over 2 months. So that isn't ever breastfed. We weren't able to get, that specifically for the New Mexico PRAMS, but that is still a pretty good percentage of mothers breastfeeding for over 2 months. And then for Arizona PRAMS, their data was from 2016 to 2017. So they reported that 94.5% of mothers reported ever breastfeeding their baby, which is also really good. It exceeds the Healthy People 2020 goal, and it's broken down by duration of breastfeeding. So breastfed 9 weeks or longer, 62.7%, breastfed 5 to 8 weeks, 3.5%, and breastfed 4 weeks or less, 33.8%. And the reason why we established this as a priority area was due to the duration of breastfeeding. So, we noticed that the percentage does decrease with duration of time. So, or duration breastfed. So this is one of the priority areas for perinatal and infant health. And then next we'll look at child mortality. The Healthy People 2020 goal for reducing the rate of death among children aged 1 to 4 years is 26.5 deaths per 100,000. And as you can see, we couldn't actually align the age group that we were able to look into, which is the 0 to 9 years old, to those goals. So that's why we stated both the goal for 1 to 4 years and then 5 to 9 years, which is 12.4 per 100,000. So as you can see here, we have leading causes of death for those 0 to 9 using the Navajo Nation Mortality Report from 2010 to 2013. We have congenital malformations, certain conditions originating in the perinatal period, unintentional injury, and all other causes. So as you can see, the 29.5 exceeds that goal of 26.5 deaths per 100,000. Let's see. And then here, looking at influenza immunizations for 6 months to 17 years. And this is using the GPRA, so the Government Performance Results Act, or reporting. And so here you can see that across, let's see, in 2019, across those IHS facilities, their goal was to reach, it's 20.6%. So all of those facilities exceeded the goal. when it came to influenza immunizations for children 6 months to 17 years. And these are national IHS goals. So I just wanted to note that. And when it comes to child first tried marijuana before 13, and this is using the Navajo Youth Risk Behavior Survey. So let's see. Yeah, from 2017. So 18.9% first tried marijuana before the age of 13. And this was higher than the New Mexico State YRBS percent, but lower than the New Mexico American Indian Alaska Native percent. The Navajo percent was much higher than the overall US, which was 6.8%. So looking at the graph to the right, first usage increases with age after 9 years, but due to small sample sizes, the estimates for under 8 are unstable and appears much larger. And next is adolescent mental health. And this is according to the Youth Risk Behavior Survey completed on Navajo in 2017. This shows the Navajo Nation percents as well as US Native American, and Arizona, New Mexico, and Utah. And as you can see, the Navajo Nation exceeded the US overall when it comes to felt sad or hopeless, seriously considered suicide, made a suicide plan, attempted suicide, and also suicide attempt resulting in an injury. And I'll just pause for a moment. And okay, so now I'm going to talk a little bit about our research study review. Again, we wanted to look at the environmental health on Navajo, because in order to address maternal and child health concerns, we need to address environmental issues present on the Navajo Nation. So let me go forward. So this is a table that shows the environmental health topic that we reviewed. So we have radon, concentration levels, coal and wood burning, fatal car crashes, and food access. And it also describes the study population and settings. So again, these are across, these research studies were completed across Navajo, and the types of study designs used. And I'll give you maybe a minute to look that over and have a drink of water. And so we have another table, and this shows the Navajo birth cohort study, the residential abandoned uranium mining and serum inflammatory potential, elemental contaminants in unregulated water, and the Gold King mine spill. And then it has the study population and setting, as well as the study design. And so we, this is a summary of those findings. So for abandoned uranium mining, there's an association between heart disease and close proximity to any of those abandoned uranium mines. And then for exposure to multiple metals, which may be in water, increases the relative risk of preterm birth by 2.5- to 3-fold. And then unregulated water sources containing higher levels of lead, arsenic, uranium, fecal bacteria, and E. coli. So those were found in unregulated water sources, which are located, across Navajo, and that has been an issue, with some people still using that water for their own daily home usage, or for like cattle or farming. And then for, let's see, the third or fourth, some homes have high concentrations of radon and carbon monoxide based on the types of materials used to build the home, and also if there are any if there's ventilation. And then, one other issue is access to healthy food. So, there are a limited number of stores with healthy food options, and also transportation to these stores were noted as barriers within that study. And let's see. Okay, so another thing I wanted to bring up about our environmental health section is that we were able to connect with Dr. Johnny Lewis with the Navajo birth cohort study. She was able to provide data and wrote a section of the report based on the most current findings from their studies. And then also Dr. Sonia Shin wrote a section on healthy food access. And a priority that came about actually, once we reviewed this research, accessed and reviewed it, was, it would be great to have like a central like database where these research studies are located, as well as any like health education materials, that were created, if any, to help to educate community members, let them know what kind of research has been conducted, what is going on, and what is being done about these environmental health issues. And then next, I will go into the workshop on qualitative data collection. So we had conducted input events. This was actually again conducted by our Northern Arizona University team, and that consisted of Marissa Tutt, Kristen Tallis, and also Dr. Nicolette Tufelshoen. So they had conducted these input events where we were able to collect feedback and responses from community members. Our target population was, mothers, or I guess the whole family unit, but also like young parents and those that may be a little bit more at risk for health issues or other, might need more support. So we were able to receive input from our advisory council on the types of questions that we were going to ask at our input events. And also they helped with distributing the surveys that we created. And so these input events were held in person. So we had sports gathering. They attended a sports gathering. I don't believe it was a health fair, but that's also another option. I know we had a lot of health fairs on the Navajo Nation. And so even just overall community events. So they actually initially started with asking them to fill out their information on, or their responses on sticky notes. And then that's how we were able to capture those responses. But a little while after that, we created our surveys or our questionnaires. Some were in paper and some were on an online platform like Qualtrics. So we also held virtual input events, and this was conducted in online college classrooms. And again, this was created, the survey was created on the Qualtrics survey platform. And these were the types of questions that were asked. So we had two separate surveys. One was for caregivers and adolescents, while the other was for providers or program or maternal and child health program managers. So for the caregiver and adolescent questions, we asked about any health teachings, any culturally related health teachings that they follow to maintain their health, any health programs that we asked them to list the health programs that they utilize, problems and barriers to accessing health services, services that they need but are not being received, and also other community needs. And then for the provider questionnaire, we asked about intervention. So again, we received guidance from, hold on. And we were able to ask about current interventions, what's being implemented now, and also what's needed. And then health information, how they perceive their clients to receive health information. And then also maternal and child health provider client barriers to accessing care. And we also asked their 5 top most important maternal and child health needs. And so this is how we were able to, this is our analysis. So we have the caregiver data was analyzed using thematic analysis, and it was incorporated to the Sa'anagai Bikeho Zone framework. There at the bottom in the middle of the screen, you see a diagram. So that's how the responses were categorized. And we had 122 complete the questionnaire, and 65% were between 12 to 29 years of age. 28% were caregivers in the sibling role, 26% were parents, and 30% had multiple caregiving roles. And for the provider, we only had 11 providers complete the survey. This included a director, general practitioner, project coordinator, program manager, and specialist. And also we did distribute, the online survey, I believe like three times. We wanted to make sure that we got as many responses as possible, but again, this was during the pandemic, so we understood that a lot of, of this population was very busy responding to that. So let's see. And now we're going to go over the findings. So whenever you see a 4-quadrant slide, it's reflective of the framework and also reflects Navajo understanding. So again, this was how the responses were categorized. So we start at the top with thoughts, and this shows that caregivers reported the need for providers, employment, homeless shelters, housing, access to fresh foods, and treatment programs. And in the next section labeled body, caregivers reported sports, cultural teachings, and parental encouragement that helps them to maintain their health. The bottom section labeled emotions, caregivers reported being aware of coping mechanisms, the need for support programs, and ceremonies that help them to stay healthy. And the last section labeled home and environment, caregivers reported the need for home utility infrastructure, safe and accessible health facilities, and traditional practitioners. And then for the provider findings, starting at the top left corner, providers reported the need for interventions addressing substance use, maternal mental health, and domestic violence, and culturally relevant specialized childcare education for children with disabilities, health promotion, and access to food and water. The next section on indicated barriers for mothers and children. So we saw that this relates also to the caregivers' responses when they talked about indicated barriers. So this included neighborhood and environment, economic stability, healthcare, community and social support, access, reliable transportation, and difficulties navigating the healthcare system. And then to the bottom right corner, indicated barriers for providers include scheduling difficulties, clients' home conditions, beyond scope of program, and economic stability. And for the most important maternal and child health needs reported by providers and program specialists include prevention programs, childcare services and parenting programs, healthcare utilization and continuity of care, physical activity and nutrition programs, food security, home utility connection, economic stability, and culturally relevant health programming and research. And next, I'm going to discuss the outcomes and the findings. So I'm going to talk about our virtual priority setting session. So again, these meetings were held on Zoom. We created video recorded data presentations on perinatal and infant health, child health, adolescent, and women's and maternal health and environmental health. So, so this was based on the secondary data that was collected and analyzed. So we made those data presentations and we sent those out. Actually, the data presentations included preliminary priorities based on the disparities that we saw between the Navajo and the overall rates. So those were at the end of the presentations. And then those links were sent out to our invited meeting attendees, including providers, maternal and child health program supervisors and specialists, and our advisory council members. So again, we held 4 separate meetings on each population domain. And then we had one final meeting where all the preliminary priorities, as well as any additional priority areas that meeting attendees felt needed to be added. So the final priority setting meeting, we had created a survey that they could take. So all of our priority setting meetings, the first 30 minutes, we spent talking about the data. And then the last 30 minutes is when our attendees took the survey. So they would just simply, we put the link in the chat, they would click the link and they would take the survey and rank the priorities. And they use the criteria to the right to rate those, to rank those priority areas. And let's see, and these surveys were kept open a few days. So we didn't close them right when the meeting was done. Because we did have low participation during those priority setting meetings. We tried to take into consideration time. But even though these meetings were 1 hour during the lunch hour, you know, it still wasn't, we still had low participation. But that's why we kept those surveys open for a few days. That way, those that were able to review the PowerPoints, those, and also if they wanted to be part of that priority setting process, they could through the survey. And now here are the finalized priorities that we had that were established based on the secondary data collection and then the priority setting session. So for perinatal and infant health, we have 6. And again, I went over mortality as well as preterm birth and breastfeeding. That data I went over it. But we also had birth defects, oral health, and large infant gestational size as some of our priority areas. And then for child health, we have number 1, mortality, number 2, substance use, and number 3, oral health. And as you can see, these priority area number, you know, there's they range, the numbers of priority areas range for each population domain. For child health, we weren't able to gather a whole lot of data. So that's why, you know, there are only 3, but so moving on to adolescent health, we have number 1, mental health. And I went over the data for that. Number 2, alcohol use, nutrition, sexual risk behavior, tobacco use, family composition, displacement and homelessness, marijuana use, cognitive disabilities, sex trafficking and violence, dating violence, and cyberbullying. So adolescent health, you know, we're able to collect a lot of data, review that data, and also we had input from our meeting attendees as well as our advisory council. And then for maternal health, our first priority is prenatal care in the first trimester. Second is adequate prenatal care, then maternal mortality, breastfeeding duration, drug use, diabetes, obesity, and oral health. So, let's see. Okay, so now we are going to break for 10 minutes. So I am going to continue We're going to be going over our dissemination plan, as well as designing and creating the report and other documents, and then going into the panel session. So I hope everyone was able to drink some water or move around. So our dissemination plan, after we completed our data collection, analysis, and our priority setting, we're able to complete a needs assessment report. And this was included in the 2020 Arizona State Needs Assessment. This is available on the Navajo Nation Epidemiology Center, which is, I believe the link is in the chat box. We also completed a PowerPoint to help community members, program specialists or managers, as well as tribal officials understand the findings. And also created was an infographic that could help, again, summarize the findings of this. And then, so we were able to print 500 copies of this report, and these were sent to all 110 chapter houses, hospitals, advisory council members, and maternal and child health programs, as well as state, tribal, and federal officials. And now we are continuing to disseminate these findings through virtual presentations, and this includes Arizona, New Mexico, Utah, and Navajo Departments of Health. We've also completed presentations at educational institutions, so at Diné College, and let's see, other universities off the Navajo Nation. And so we're really excited to have this report and to be able to start moving forward to addressing the priorities that were set. And we're actually able to receive some funding from Arizona Department of Health to continue on with our, it was an advisory council, but it is now our Navajo Maternal and Child Health Committee. So we meet monthly, and then we also have a subcommittee that meets every month, and we are working toward, planning how to address these priority areas, as well as improve capacity of these MCH programs on Navajo. So, and we're also getting ready for the next needs assessment, setting up those partnerships and collaborating, and so we can, be able to, request more data and create another report in another 5 years. So next, we will, oops, okay. So next, I will hand it off to Craig Manning, who helped to create and design this report. So he is going to go over what he had done to complete that. So Craig.
Thank you, Amber, very much, and welcome everyone. I'm Craig Manning. I have spent part of my career at the Centers for Disease Control, and my group their focus was on hantavirus. So that means we made friends on Navajo within the Navajo Epidemiology Center, and also I've been teaching at the college for a number of years. So my background is basically communications design, and it was clear on a project of this sort, where we're going to be amassing a lot of data, that we need to talk about the data, we need to talk about the visualization, the organizing of that data, the visualization, the reporting out, the sharing out, the dissemination, so that this document and its information can be actionable when it comes to strategies for improving public health outcomes on Navajo Nation. So my role was to put a document together based on the information that I was given. So that, and I'll speak a little bit under the, kind of like what's going on under the hood, so that there could be a process whereby a document is created that goes to those many individuals and those many institutions that you saw in the previous slide. So there is some forethought that had to happen here, because we're a team working, creating a document, and we use Microsoft Word for that, as does most every other team working collaboratively or something comparable to that. But at a certain point, when you're needing to design and your Word document is finished or nearly finished and been signed off by everyone, then you start asking questions like, how can we put this into lots of people's hands? And one of the answers to that is try to make it appealing and try to make it look as if the information in here is worth reading. So that takes us into the realm of design. It takes us into the use of color and photography. And I wanted to speak a little bit about that in the context of today's presentation. So the screen you're looking at right now looks an awful lot like the cover, and it is. It's the electronic layout of the cover. The point to mention here, I think that's worth sharing, is that to do this in the software, perhaps you could do this in Microsoft Word where you can move elements around relatively freely. It's not so easy, however. So we're using something called Adobe InDesign. And I'm not I don't have anything to do with Adobe other than that this is a product which does page layout. You may be familiar with other stuff that Adobe makes, like Acrobat. There's other products out there that do this with comparable finesse. And that's, just wanted to show you the cover. If we could have the next slide, please. We're diving in a little bit more deeply so you can see the layout lines, you can see the boxes that allow the easy movement of type, the varying widths of column. And this is all kind of the behind the scenes architectural aspect of how one puts a document together. So one of the things that's rather nice about page layout software that's not so easy to do in Microsoft Word is you can have a column of text followed by a pie chart to its right, as we would see here. And this enables us to put the information, the textual information, right next to the visual interpretation, the visual information as well. And I think it also makes this for a more interesting looking document as you don't have to confront a wall of text, although we did have pages that were largely full of text. And if we could see the next slide, please. This is another example, maybe zoomed in a little bit more, where the workspace looks perhaps kind of cluttered, and I can assure you that at times it absolutely was. But there are all of these elements that have as their goal to declare the information that is coming out of the data so that we are making it easy to understand why the recommendations that are here are important. So if we look at the next slide, I wanted to speak about and the one after that, actually, please. Yeah, here we go. Now you may be beginning to see that we are using in the design of these documents certain common colors and certain common typefaces. And this is kind of both across the Epidemiology Center here on Navajo and also within the college, the Dinek College. And the idea is that we're trying to create an identity whereby these documents, even with just a casual glance, already start to give up their information to you, so that these become, you become clear from the moment you recognize this, that there is some, there could be important information here. By way of comparison, our colleagues at the Arizona Department of Health Services, if you look at their website, they have a design guide. And it speaks very specifically about what kind of font is to be used in what set of circumstances, where the logos can go, what the colors need to be, all of which is to strive to create a consistent look to the products that they are putting out into the world, just like we are doing the same thing here. So next slide, please. And again, I'm not a salesman for Adobe, but I was letting people know that for colleges and universities, if you have a .edu, which is the way I'm doing it as a consultant for the college and for the Epi Center, it's costing me something like $30 a month or thereabouts in order to be able to use these software products. They're by subscription. The simple idea being that when you are collaborating with a team, everybody can work in Microsoft Word up until rather late in the process, and then we move things into Adobe InDesign, and then we start sending out PDFs. And the PDFs that you see can be turned into the printed physical documents that we can ship out to people in the mail, and or they can go up on the websites as they have, in this case, like on the Navajo Epidemiology Center. So, and if you think about that, we have really taken a product, a body of information, a technical, a document with from which decisions will be made and actions will be implemented, and we've tried to move it out into the world such that those who see it are interested in, getting taking advantage of the information that is there. And one last slide for me, please. Next one there. I was hard pressed to figure out what am I going to do for colors. And the suggestion came, just type in Southwest color palette into Google, do a Google search and find what the results are when you go and retrieve, you see results for searching on Southwest color palette. And something like this is what you will get. And so I had been scratching my head for a time to try and have a small number of colors that will work across a variety of publications and even within PowerPoints. And so I took a subset of what you're seeing before you, and some of the legwork and some of the decision making that actually could have taken a long time was much easier to do once it was clear to me that we needed to find a palette that reminded us of the Southwest and would work across the documents that would be created by, some of the documents would be created by the Epi Center and also at the college. So I say to those of you who are working on the data side of things and thinking about reports, I'm always asking my colleagues who are working on the data collection and interpretive side of this, inviting them, let's give some thought to what the final finished version of this document might look like, and whether the costs of taking on board someone who does this layout and design is actually warranted, is actually justified. And so it's an important question to be asking, because we do have a role, who are doing this this design stuff in the service of the dissemination and in the service of improving public health outcomes. We want to make good looking stuff that people will read. So I think I can leave it there, Amber, and say to everyone that it was great to work on this team, because they were so receptive to the inclusion of this process into an already busy process, as you have seen from the previous PowerPoint. So I think I can leave it there. Thank you.
Oh, thank you, Craig. That was a really good overview of your process in designing the report. I really like how you did looked up Southwest colors. Those are really nice colors.
Very familiar, yes.
Yeah. So now I'm going to talk about implications for implementation in tribal communities. So, this is just going to summarize, all kind of what we had done to complete this. And so we partnered with our Tribal Epidemiology Center, our tribal and state health departments to work toward ensuring that we had all the adequate support and guidance and information that we needed to conduct this needs assessment. And, if possible, since we are based out at Diné College and Northern Arizona University, it would be great if you could also collaborate with educational institutions if you were to implement this and work with maybe their public health program. This was definitely, I think it was a very great way to give the public health students, real world experience in a public health function. So conducting a needs assessment, that's what you learn. And then they're able to be a part of that, data gathering process. That wasn't their only role. They, were tasked with looking up some literature and also just trying to understand, also receive their input, because a lot of them, had caregiving roles. And so they were very helpful, not only with the data analysis, but also the qualitative data collection and analysis when they could be. And so another key point is to, establish an advisory council. And we're fortunate to have that previous PRAMS advisory group that actually Del Yazzie at the Navajo Epicenter, he was, maintaining that advisory council, and he was able to allow us to take over that and use them as our advisory council. So that was very helpful, and they did provide a lot of guidance. I think initially we some of our advisory council members were providing a lot of materials for us, so we could work off of what they have done. Specifically, first things first, on the Navajo Nation, we worked with them to come up with the health indicator list. So the health indicators that we needed to look into, because they have completed a regional needs assessment, but only for the Arizona portion of the Navajo Nation. So with their feedback, with their materials to work off of, we were able to complete this needs assessment, as well as providers. They were very, key also in helping us to understand, health for mothers and children, what we should be looking into, what questions we should be asking. And also our program, our MCH program managers, they understand, the needs and what needs to be done to help, their families and their clients. So that was very helpful, and also including cultural knowledge keepers. I myself grew up in not so much a traditional household, but I went to Diné College to learn more about who I was as a Diné woman and my history of my people, and also just who I am. And so, I had, knowledge from my experience in attending Diné College, but also looking up to our elders and those who, those within our advisory council who are those cultural knowledge keepers. And they were able to assist, when things weren't very clear for me. They were able to provide more feedback, more information, and just, set it in a good perspective. And one thing I had asked when we started to write our report, we had a specific time frame to get it done. And so I asked my team, when you're writing or when you're designing, make sure you are, you have a positive mindset, make sure you're thinking good thoughts. Because in the Navajo way, when you're creating something for somebody or even yourself, you're supposed to create it in a positive mindset. That way it, in return, it blesses those that, get to see it, or get that, those that you're gifting it to. So, I wanted to go for, I wanted this report to be something that was going to bless those that are going to read it, that are going to, want to understand our findings. So, just keeping in mind, those cultural teachings, and incorporating it into your process. I think that's what helps to ground this report and really resonates with our Navajo people. So again, include cultural teachings as part of the process. Use secondary and primary data sources where available. So we had to really use what we had for the secondary data analysis. And even when it came to the qualitative analysis, we had to do our best to adapt those input events virtually. And we used what we had. We had college classes. We had Diné College. We're part of the public health department, so we had public health courses, and so they were able to utilize the students within those courses to help with the qualitative input. And then our secondary data came from online data sets, came from reports, came from research review, things like that. I think it really helped to ensure that this report made use of the data that is available. And, going forward, I hope to have more recent data, that way we can see, how are things improving, where can we, put our efforts and our support and our funding. So lastly, create and distribute reports and other materials, such as, Craig was describing earlier. We created the report. We went into creating an infographic and our PowerPoint presentations, and we're continuing to present on this. We're continuing to, I guess, model how it could be done in other tribal communities. I know not all tribal communities have an epicenter. They may not have, access to any kind of real health data, but I'm hoping that, this helped to demonstrate how it could be done in other communities, but also, bring about collaboration and partnership to improve Navajo health. And just keeping in mind, in the end, who you're helping, who this is going toward, and ensuring that they are also a part of that process. So, and let's see. Now we will actually move into, I'd like to acknowledge our partners, stakeholders, as well as our Navajo, mothers and children. And I really thank them for, all of our partners for their contributions to their guidance to, even down to the littlest things. It's been very beneficial for us to move forward and to establish, a maternal, even just establishing a maternal and child health project at Diné College, that is awesome. And I'm so honored to be a part of that. So yeah. And now we will move into the panel session. I myself will be a part of that. And I do have our my colleagues that are also going to be able to answer some questions specifically to what, where they helped with this or assisted with this needs assessment. And I believe the only person that was not available today is Dr. Christine Benally. But if she is on the call, let us know. And yeah, so our moderator will be Dr. Nicolette Tufelshoen with Northern Arizona University. So I'll just see. Should I leave the panel session slide up, or?
I'd leave the panel session slide up because I think what the best way to sort of move forward. So first, good afternoon to everyone. It is afternoon, whether you're in Arizona, New Mexico, or wherever. We're just so pleased to have so many people attending. I think what the best way to get started here would be to have each one of the panelists, as listed here on this slide, introduce themselves and perhaps say a few words about the pieces that Amber did present. And if you feel as though you wanted to add a little bit more information, we do have about 10 questions that have been posed by the attendees. So it'd be great if we could get to those. I think we have about 45 minutes left.
Mm-hmm.
The schedule is till 1:30. Is that correct, Amy?
Yes.
Okay.
That's correct.
So Kristen, could we have you start, and then we'll just move through the panelists as they're listed there on the slide.
Hi, everyone. Can you hear me?
Yes.
Okay, great. So Yat She Kristen Talashini Sheikh Nawahni Nishlan but Ani Bashichi Twitchini Dashiche Dog Uzatlana Dashana. I was a part of the qualitative data collection as a graduate student in the Master's of Public Health program, and I work with Marissa on that. And I'll just tag Marissa.
Hi everyone, my name is Marissa Tut. I'm from the San Carlos Apache tribe and worked on the qualitative portion of this needs assessment.
Christopher Dickerson. I am faculty of public health at Diné College, and my role was bringing in particularly the large data set. So the American Community Survey and the CDC Wonder data in order to try and get some broader base beyond the reports that had been published.
Great, thank you.
And hi again, I'm Craig Manning. You heard my little bio from before, formerly CDC, working with the college, working with the Navajo Epidemiology Center, and having had the great pleasure of working with this team here.
Great, thank you. Martine?
Sure. Good afternoon. Buenas tardes. My name is Martin Celaya, and I serve as the chief of the Office of Assessment and Evaluation here at the Arizona Department of Health Services. And so I work very closely with Diné College on this project and provided technical assistance on where it needed to be. And so I also am the PI for the statewide Title V Maternal and Child Health Needs Assessment, which is why with this needs assessment, fed information to for our Title V Maternal and Child Health Block Grant. Low-key, I'm also a doctoral student at the University of Arizona in the Maternal and Child Health program with an EPI minor, doctoral minor as well. Happy to be here.
Corinne? Is she with us? Yeah.
Can you hear me? Can you hear me?
Yes.
Yes.
It's a little blurry, but it's okay. Go ahead.
Okay. It won't let me.
Oh, try one more time. Uh-oh, we may have lost her. No, she's connecting again.
Oh, hi. I'm sorry. Hello, my name is Corinne Dohai. I was part of the quantitative analysis team within a college. Specifically, I helped with the report and aiding in the perinatal and infant health section of the report.
Great, thank you. We had developed a couple of questions coming into this panelist, but we do have several questions from the group. But I did want to pose the question we had developed for Corinne, and that was really related to what kind of skill set she had when she went into the project as a student, and then what maybe got developed as a result of her participating on this project.
You want me to answer that, Amber?
Please, yeah.
For me? Okay.
Yeah.
I think honestly, coming on to the project, it was a lot of just what I learned rather than me actually performing the skills. So throughout my time within a college, a lot of the time they really taught us about how to perform statistics analysis, and they talked about analyzing the findings and I guess how to look for data and how to interpret it. But when we went into our practicum, there was a lot of what we were on our own, especially during the pandemic. So we kind of learned a lot of, me and the students, I guess we learned as we went along. But we did really have good mentors, which were Mr. Dickerson, Mark Bauer, and Amber to help guide us along. I think at the end of the semester, me and my classmates, we really did gain a lot of knowledge and I guess a more wider skill set on how to actually perform the duties that they required of us during the class, rather than just learning about it. In a way, I think it really helped us to understand more about what the whole public health, I guess the data side of public health is. And I think we really did learn a lot.
Great, thank you. So I kind of group the questions into kind of overarching questions and then some very specific questions about the data. Amber, you had talked quite a bit about the fact that we worked with Dell at the Epicenter to essentially kind of use his PRAMS advisory group. And one of the questions is, what is your advisory group structure and how do we keep them engaged?
Yeah, so our advisory group structure. Well, we meet monthly and I tried, well, and when they were an advisory group, we would just keep them updated on, well, we would kind of like break it down to, what kind of data that was needed. So we, ask them if they have, data sources or if they could provide any kind of data that would be helpful. Also inviting other people that might be our program managers or other people that might be interested. So we're asking, during our meetings, we need this, can you provide it? But also keeping them updated on what we're completing so far. So, in the beginning, it was basically just trying to put together or just figure out like our our process for this. Okay, so we need data. We need to start analyzing data. We need to start writing the report. So they were really kept informed of each and every activity, as well as once they moved on into a committee, which was just recently. Now we're trying to provide them more, do with this upcoming funding that we're receiving. We're trying to make sure that we're, improving their capacity. So we'd like to offer like trainings within like, even if it's not Navajo cultural related or data analysis and management related. We have a lot of maternal health trainings that are up and coming, and also we hope to provide funding of some kind if needed, for, I know a big thing with programs or incentives. So I feel like that's what's keeping our committee engaged is, ensuring that we're helping them so that they could also in return help us. That's our structure going forward. We do, I am trying to set up a subcommittee, or we do have subcommittees, but we haven't exactly just moved forward just yet with planning and strategizing how we're going to go forward with addressing these priorities. But there's so much going on. This is such a new big area that it's a lot of work to work on, just on I guess administrative things, and then also take on the committee itself. But it's been great, and it's much needed. So
great, thank you. The next question is really about Hataklis and whether we ask questions specifically about cultural teachings, or how do you think this project, you've talked a lot about the cultural framework, and whether we did receive other kinds of guidance in terms of the application of that framework.
Yeah, so I feel like we have we have some staff that are Navajo, so we were able to incorporate what we knew about the Navajo culture and our teachings and our life ways. And I know I've heard Kristen also like mention going back to like her family, and she would always mention like going back to her family to understand what we were trying to do, how we were trying to build this framework and this process. So and I myself, I was taught under at Diné College, and I had one or actually two instructors who were Hataklis. So I have notes and all kinds of notebooks on the notes that I've taken from their courses. I wanted to put it to use. So definitely going forward though, it is going to take a lot more engagement with Hataklis, I think, because of what the kinds of activities that we want to implement. And they have different specialties. So some, are, specialized maybe in like, maybe, what was it? Like, I guess like in the prenatal like care realm. So I'm interested in learning more about that and also engaging more with them as we move forward.
Great. Kristen, yeah, did you want to add anything, Kristen?
Yeah, I think that was definitely overlooked, and the part about looking into providers and health professionals to really get their feedback in the qualitative section. And I think it's thinking about it, thinking backwards or to the time we were collecting that information, we did get a lot of, the students themselves, they talked about it. They mentioned it in their responses. And I think that was something that was sorely overlooked. I hope that, this a part of this continuation of this assessment includes them, because these health professionals are these hatathlis. They're at these the IHS facilities. They're in our schools. They're at home. We use them for our own family health. So definitely, I think that was overlooked in this part. So thank you for bringing up the question, and hopefully this is something we can work on in the future.
Great, thank you. And also speaking about the future, one of the questions is about how were fathers integrated into this project, recognizing that our charge was sort of maternal and child health, but how do we think we also engaged fathers and even grandfathers' perspectives in the work that we did? Or, is that something else for the future? Now, Kristen, I don't know if you want to answer that. I know you and I have had that conversation before as well.
Yeah, I think that was one of the parts of the qualitative section that we did not want to miss. So when we were collecting data, we didn't exclude fathers, we didn't exclude grandfathers or uncles from this. The same questions, hold on one second, let me see if I can. Marissa, do you want to add to it? I'm gonna check on my sound.
What was the question?
About inclusion of fathers and other male caretakers.
So when we were doing our input sessions, we kind of asked questions broadly, not tailoring it to mothers. I think we even went in with kind of just having more of a family kind of view, because like the way I thought about it is that it takes a village to raise a child. And so that's kind of what our mindset was. So that's why when asking our questions and input sessions, we had uncles, brothers, cousins, dads, grandpas answering our questions. Does that answer the question?
Yeah, I think so.
Okay.
Yeah, thank you. Another more kind of broad question about the work that we presented was, are there classes to teach how to use these kinds of data resources?
I think there are, if you're going into data analysis, but not just specifically just CDC Wonder or ACS. I know we had to orient the students to the American Community Survey, once they started helping, because they did actually, we assigned them sections of the demographics of the report to analyze and also write up. But I don't think there are like classes other than like general data analysis classes. Christopher, have you heard of such a thing?
I would be hard pressed to think that Census and CDC do not have such workshops. But I was aware of these and had worked with these sorts of data sets as a result of my doctoral program. So that was where my background and knowledge had come from. It wasn't from, so in the process, we didn't go looking for that information, because in our case, I had already had experience through my doctoral training.
So some of the other strategies might be consider taking a course at Diné College, or
Yeah.
they could have worked on one of these. I mean, the students got very much of a crash course in these data sets. Some of the conversations we've had since this assessment has been distributed is with resources that the Martins program is providing. Could we provide some kind of webinars that would provide more detail instructions about how to use some of these data sets, such as the Wonder data set, how to get access to some of the immunization or other kinds of data that you that was identified here. And that kind of, go ahead, Christopher.
Yeah, I was going to say, and some of that requires thinking about how you operationalize and the limitations of the data. So that's something that we didn't get to discuss quite as much. We've answered the 100,000 question, but if there were fewer than 10 events over the time period that we were requesting, CDC doesn't release it. And as you saw, we had to use American Indian Alaska Native as our defining because the CDC Wonder does not have tribe-specific information. Census with the ACS has tribe-specific, but our estimates were those 3 counties, recognizing that included Native Americans in Flagstaff and Native Americans on the Hopi Reservation in Navajo County. So this was not a pure Navajo specific estimate when we were using the CDC Wonder. And so we have to think about those sorts of issues when we're working with these sorts of data sets.
Mm-hmm. Right. And you did answer the question someone posed about the Wonder data with American Indians, Alaska Natives. It did potentially include non-Navajos in that analysis. Another question asked if you can access the immunization database if you work with IHS. So if you remember the immunization resource you used, what kinds of parameters were there in getting that access to that data?
It just seems like access. Myself too, I would have to, log in somehow with IHS, credentials, but I just popped, that link in and I was able to just request what I wanted to look at and it popped up. So, I can make sure that those links are available, or that, especially that one, because that was just given to us by a provider here at IHS, and she's like, oh, this might be helpful. Go ahead, Christopher.
I was going to point out that some of these were time limitations. We know that IHS is creating a data warehouse that, given the opportunity to create agreements, we might be able to access in the future. We know that it would take like a 3-month lag time, establish relationships where we might be able to get Navajo specific aggregate data, but the time limitations between when we started and when we needed the report meant only publicly accessible data was what we could work with.
Great, thank you. Another question asked about numbers of children who are referred to Navajo Children and Family Services for foster care or adoption. If we had data on those issues, and if we had any thoughts about whether those adoptions stay on Navajo Nation or are adopted off Nation.
So we don't have data on that. We did put in a request with that program to see, to review the numbers, like very basic data. And I'm not too sure myself if how the adoption process occurs on Navajo, if they're kept on Navajo. So I'm sorry, I don't have that information. Does anybody else perhaps? Okay, doesn't look like it.
Okay, great. And there's a very specific question here about influenza vaccine targets being why is the influenza vaccine target so low? Do we think it was a result of COVID, or any other thoughts there?
We know it wasn't due to COVID because those were the 2020 goals set in 2010.
Mhm.
And the exact way that they set that, I'm not sure the underlying mechanism, but that was the way Healthy People 2020, they took prior data and increase it by 10% for their target numbers. That's the best I can answer, but yeah, those targets were set back in 2010 for 2020 goals.
Yeah, and the goals for others, like I forget which ones exactly, but they were still very low. And so and all the most facilities like exceeded those goals also. So we don't know why they're so low.
Great, thank you. That's pretty much the questions that have been submitted here. But I did want to give Martina an opportunity to maybe talk a little bit more about why, how it came to be that in this round of maternal and child health assessment reporting, that there was an outreach to both the Navajo Nation as well as the Intertribal Council of Arizona, why that step occurred just within the last year or so, and what the plans may be for future assessments.
Sure. Thank you, Dr. Tuflashon. And so I'll quickly talk about the other in terms of like exercises or courses on like database management from our perspective, right? So the state doesn't have anything per se, but I know there are some like online resources, like CEC does have like a self-guided EPI 101 sort of way that talks to you a little bit more about data-based like analysis, downloading data, exporting data, and talks about some of these things where you have to data suppression guidelines. And so also the people that put together the Healthy People 2020, 2030, and whatever decade you're on, also provide guidelines as to how to do proper benchmarking. So those are also some helpful guides that are publicly available that we tend to look at. Each data source is going to have their own unique sort of nuances. Dr. Dickinson mentioned the ones with CDC Wonder, and then there's other like BRFSS, the Behavioral Risk Factor Surveillance System, and the National Survey for Children's Health. They don't all follow the same guidelines. So you really have to look at which is really frustrating at some points when you're just trying to get the public level data. But the good thing is most of the time when time is allotted, you can request those data sets and do your own analysis, right? That's the bottom line. But we're very proud of this partnership with the Net College and the Navajo Nation here and the Intertribal Council of Arizona, because, time and time again, we see that a lot of our maternal health and outcomes, are not equally distributed through our different communities. And I think I'm preaching to the choir by saying this statement, but we do know that our indigenous communities carry the largest burden when it comes to maternal mortality, morbidity, infant mortality, right? Infant morbidity and adolescent suicide as well, like in a sense, adolescent mortality, right? And so given that Arizona is such a large state with such diverse backgrounds and that there are 22 sovereign nations in it, it just made sense that we would do a more intentional outreach. And I have to give credit to our past Title V program manager that I saw here, Geraldine Hashkon. And so she actually incepted the idea of working with Navajo. She is of Navajo Nation herself, to do these sort of tribal assessments. So she really kind of did the push. She pushed me to be like thinking more like intentional, right? Because we do know that one size does not fit all when it comes to public health programming anymore. That's not going to do it. And so, but what we do need to do is we need to start hearing from our communities as to what is the need, what is the true need, And so if you all were to look at the larger Title V Needs Assessment Report, which is available on our agency website, you will see certain tenets of community-based participatory research as part of the needs assessment, and this being one of them, right? And this is one of the things where ADHS did not come to Diné College saying, you need to implement the survey, you need to implement A, B, and C, and we need to know 8, whatever. The only thing we needed to say was, we're trying to better understand the needs for maternal and child health services. And you can define that however the nation wants to define that, and come up with the methodologies that are best, that the nation prefers, kind of going through these exercises. And Diné College Navajo Nation just did their thing, and we were just here to support doing all your things. We weren't concerned about, being replicable research, generalizable research. That was not the aim of this ever. The aim of this was to have produced data that could be incorporated into the statewide needs assessment, but most importantly, that was meaningful to the Navajo Nation, and they can do something with that. And so we're very proud of this approach when it comes to public health assessments. And in fact, this relationship, Amber and I are going to present at a national meeting with the Association of Maternal and Child Health Programs here pretty soon. And our HRSA funders, we've invited Amber and the team to present to HRSA as well, the Human Resource Services Administration. And they're really looking at this as a model for future assessments. There's all of these tribal epicenters that are within state boundaries, that cross state boundaries. And in fact, with this partnership, we partner with New Mexico Department of Health, which we work very closely on with PRAMS, but in a different manner. And so, it's about respect. It's about listening to those that are traditionally not heard, as one of the principles of our statewide needs assessment, which unfortunately tends to be sometimes indigenous communities, migrant communities, mining communities, monolingual Spanish, and so forth in our state. So we wanted to kind of do that reach out. We had time. We started this process 2 years ago, and things take time. I'm not calling this a CBPR, and Dr. Tu, for sure you can tell me if it's not or not, yes or not, but it takes time. It takes time to build a relationship. It takes time to have that understanding, and kind of walk us through our process to understanding what are the needs. And so Amber and the team has gone above and beyond when it comes to establishing the steering committee, because usually assessments happen and everybody goes home and there's a report published and it looks pretty and it looks great. But you all have taken the extra, really done action research there and taken to a next level where you have the stakeholder group. And we as a state are very interested in continuing to foster this relationship, and therefore have made additional Title V monies available to support some of those initiatives that Dr. Tufo-Shone and Amber Rose Waters kind of mentioned earlier as well, with increasing data capacity at the nation, right? And probably proposing, I can spend a whole day talking about proposed projects for students to encourage MCH workforce development. And I think we'll be doing that soon. So, but again, there's a large impetus at nationwide, right? A large push for health equity. And health equity is not just in service delivery or social justice, right? But it also goes back to data health equity and data equity. And what does that mean, right? And so even going back to how funding mechanisms to support certain communities. And so because of this large push and interest for our bureau to move the needle when it comes to health equity, we have 2 priorities on health equity. We were going through this as not blind, but I want to say just trying to test the waters, because we haven't done this before. Like Dr. Tufo-Shone says, we haven't reached out to the tribes and been let's assess the needs. And I think we're all very, very, very much happy with the findings. And we're here to support the nation in implementation of those recommendations or priorities. So that was a whole wraparound way of answering the question, but I hope that did.
But you did touch on dissemination, and one of the questions that has recently come in is what kind of dissemination efforts we have to the Navajo population that don't speak English and may have a lower reading level, because we have talked a bit about reaching out to the departments and service organizations in Navajo Nation. But any thoughts on that from anyone that's on the panel?
Yeah, so with funding from Arizona Department of Health, we plan to create some audio PSAs to air over, KTNN to radio based on the Navajo Nation, and those will be in Navajo and English. So things like that we're planning to do within the next coming months, and also that kind of makes me think of other ways that we could incorporate the Navajo language. But really, keeping that in mind, that's how the report was written. We tried to make it very understandable for, not just people who know data or can understand, data, but those that are general community members. That way they can, they're located at every chapter house now. So we're hoping that, they're able to understand it and see, that there's priorities set, and, we can move toward working on addressing those. So.
Great.
Yeah.
Thank you.
And I could add something to that. I think Amber's response was wonderful. I think as I read that question from the attendee about disseminated, yes, I mean, upcoming will be in Navajo in the form of public service announcements coming out over radio. And really the way we think about this now, I believe, is that we can be doing reports, we can be doing PowerPoints, we can be doing public service announcements, we can be doing audio recordings, we can be reusing our content and reusing our messages and repurposing them. And from a certain vantage point, with the technology that is available and the infrastructure that is available, for example, radio stations, newspapers, and social media, it's a straightforward process, so long as there is budget, so long as there is support, to take these messages, to take these recommendations and move them out into the wider community, so that the discussions about public health and improvement of public health outcomes is just, it's kind of like, I want to say, we've only gotten started. We've read, this has been Netflix season 1. Netflix seasons 2 is going to be even more powerful in terms of how we move this out into the community.
Mm-hmm.
Great, thank you. Another question has come in that harkens back to the advisory committee. And the observation is that it seems to be comprised a lot of non-Navajo community members. If that's correct, how do we think that might have impacted the priority setting?
Well, the priority setting was a mix of non-Navajo and Navajo based, because we invited, providers as well as program managers, and it varied. As for our advisory committee, I felt like there was a strong, Navajo representation. But I think it varied for the priority setting. But when it comes to our advisory council, I think we have a bigger Navajo representation. So.
And if, correct me if I'm mistaken, but before we formally finalize the results, we actually had the priorities reviewed by Navajo Department of Health, correct?
Yeah, we did send them the priorities, that way that they could review them, and so.
And one of our understandings of the objective was to provide that baseline data, so organizations, programs within Navajo Nation, whether they are tribally funded or federally funded, would have some data to be able to apply for external funding, so that there was that baseline data that if they wanted to focus on a particular health issue, they had the data to move forward. So, though the audience certainly is the citizens of the Navajo Nation, we were also very aware of the lack of information that organizations were making decisions. So a lot of decisions were sort of, just based on perceptions and weren't really evidence-based and data-based. So I think that was also, and many of the advisory board members are actually in leadership roles in those organizations. So I think it kind of varied. If you see the whole list of advisory board members, I think it varied as to whether it was providers who may or may not be Navajo, as well as program directors.
Mm-hmm.
Let's see, other questions. Do we have an idea of what the reading level is of the report?
The intention was around 5th grade. I won't say that we compared it to the newspaper to be 100% certain, but that was the intention in the writing.
Thank you. There's also a question about the data on the birth defects and whether are there any plans to delineate that to follow through on that data, or what do we know about any more detail on those birth defects, since it was in terms of mortality.
Yeah, so we weren't able to gather Navajo specific data. I believe the report that we gathered was from Arizona Department of Health, the birth defects monitoring program. So, and that was just Native American specific in Arizona. So, and then I believe the CDC Wonder, right, Christopher, we weren't able to retrieve data because there were less than 10
yeah, the overall childhood deaths was 36, and if I remember right, that was actually aggregated over a 3-year period.
Yep. Yeah.
So we could not delineate any more than that simply because of the confidentiality and data suppression. So we can't follow up currently using the available data sources.
Yeah.
And I think in the time that we have left, I want to kind of create an open question that is kind of compilation of some of the things we thought of in preparing for this workshop, as well as some of the questions that our attendees have asked. What do we think we would do different? I'm assuming 5 years will be, maybe 4 years, we'll be planning this again. Would we ask different questions in the qualitative data? What would we might do different, particularly if we had more time? As Christopher has mentioned several times, we were sort of we had a short time frame, so we were working quickly to get the data we could access. But with a bit more lead time, do we have a sense how we would maybe learn from this, as Craig says, from this version 1 or this Netflix 1, what we would do different, or how we would expand, or how would we build on our experience?
I see Martine's hand up, so.
Yeah, I'll just quickly add something, because obviously in 5 years is the next statewide needs assessment, and I am not interested in doing this mega needs assessment in 5 years again, all in 1 year. So I think a strategy that we're starting here at the state is we're going to be doing this little by little, year by year. We'll add another type of assessment to kind of do a little bit deeper dive into this baseline. Is statewide is what we're doing here at the state. And we're actually doing some additional assessments, right? Amber's going to help us do a little bit more digging into barriers and limitations to accessing prenatal and postpartum care amongst women. So that's going to do even deeper dive into that maternal health population. So I'm envisioning that now that we have this baseline and this sort of relationship building, I'm hoping that this will continue and do that deeper dive so we can nuance those things about birth defects, right, with the Indigenous community, or ACEs, or, adolescent mortality, do a little bit more as to understanding more of that indicator and why it's behaving so differently in this community versus the rest of the state. I think it's with more of that intentional to, from a state's perspective, do that more, more culturally humble but also agile public health programming. Right. And so continue to the experiences that we learned with the Maternal Health Innovation Program and this group as well, but for the other domains. So that's just my 2 cents there.
Great, thank you. Marissa and Kristen, do you think you would go about the listening sessions or input sessions in any different way? I know that the grander plans did get dramatically modified with the restrictions of COVID. Do you think you would take on the task a little bit differently, or what do you think you've learned there that could contribute to the next round of getting community input?
Yeah, I think if we were able to do, hopefully in the future, we have more time, and of course the ability to meet with the community, whether that's at these community events or yeah, just being in the community, I think was the part where we would hope, and we know that that's where we would get the most information, and with a genuine, bi-directional conversation between, us as asking them questions and trying to, clarify or help them along, and then them giving us their information as best they can. I really think that the data that we got for them, I hope that it was used to make sure that there was going to be a conversation between the community and the programs or the health professionals that provided the services there, as well as get an idea of what they hoped for their own community to have. And I think in the future that we focus, especially with the adolescents, about what they see their future, how they see their environment, how they see their health, and how they see their health and culture interacting, so that we can build a community, a nation that's founded or really emphasizes that. So for me, I'd hope we'd focus on the idea of indigenous futurism. What do we want that is not what we see, maybe something we don't see in Flagstaff, like this is a very non-native community, non-native population, so what they have here in Flagstaff is made for them. But on the Navajo Nation, I know there are things that we specifically use to maintain our health, and things that we'd hope we'd have in our community, and to maintain our health. And I think those ideas come from the adolescent population. So that's where I hope it goes as well.
I think Kristen provided a really great answer, and kind of being a part of the community and kind of understanding what's needed there. I think kind of just speaking more on the logistics, after we did the best that we could with the input sessions, we did notice that we didn't get younger parents involved. And I think that is something that could probably provide a different perspective in what is needed in the community in regards to maternal and child health.
Well, thank you very much. Anybody else have any other thoughts who worked on the report about what we might do in the future?
I'm excited for more time to complete the report. And I hope that, we're collaborating and, creating like data sharing agreements with the areas that we weren't able to collect data, like children with special health care needs, social services, education. Because if you look at a, comprehensive, like the comprehensive state needs assessment, they have that information. And those are just things that, we weren't able to get, due to the pandemic and due to other challenges and limitations. So we hope to overcome those this time around.
Yeah, I mean, that's basically all I would add is like the data sharing agreements with CDC so that we could get Navajo specific, but as those take a bit of time, they take some planning, and that's all. That's what I would be working toward, is trying to establish those agreements so that we can access that type of data.
Thank you. Well, we have now come to a close in terms of our time. I do want to point out to all of our attendees, particularly the 72 of you who stayed on through the whole time, that our emails are in the chat, and they're probably also in one of the links that you've received. So if you do have specific questions, you have a sense now who worked on which components, and please do reach out. We are preparing ourselves for the next time. And so we would certainly invite suggestions and hope to be able to answer any questions you have. So thank you very much, and have a good rest of your day, and you do let us know if this was a helpful session. Yes. Amber, do you have any closing thoughts?
Yeah, everyone, thank you so much. And again, reach out if you would like to be a part of like the advisory or the Navajo MCH committee, as well as, be a part of the process for the next needs assessment.